I hope that you take an opportunity to reflect and to join in the celebration of all you contribute to our communities with your colleagues. It's a fantastic profession. Now, on to this morning's session. Please bear with us if there are any technical glitches. I think it's amazing that we're able, in the course of over 14 months, to be able to host a worldwide virtual conference. We're getting better at that, and but with the best will in the world, sometimes the technology can be a little bit tricky. So bear with us as we reach for our mute buttons, bear with us as we reach for words to fill in the gaps on occasions. My name's Frank Tracy. I'll be your host and have the pleasure of doing that with Neil. I have a role as the Chief Executive of Children's Health Queensland, which is a statewide paediatric hospital and health service. I also have the honor of being a board member of the International Foundation for Integrated Care. And I'm delighted to be able to host this session this morning. So moving right along, we have our first speaker is a face who will be familiar to many of you. I think it would be, yes, I don't think it's too far of a stretch to refer to him as the godfather of integrated care. But he might say a little bit more about that when he comes on. It's my great pleasure to introduce Professor Nick Goodwin, who's the director of the Central Coast Research Institute for Integrated Care at the University of Newcastle here in Australia and the Central Coast Local Health District. Nick will be very well known to many of you, and his session will be about leading and managing integrated care programs successfully. More pointedly, it will be lessons learned from international evidence and experience. Nick, I'll hand over to you and welcome.
Thank you very much, Frank. It's a pleasure to be involved in the conference today, 21st conference. Amazing how the years pass by so quickly. Here on the Central Coast, of course, the traditional custodians of the dark and young people. I pay my respects to their elders, past, present, and emerging. Just going to pin the presentation on my side so I can see them. So yes, so today, this morning, I'm going to lead a conversation around what we have begun to learn around leading and managing integrated care programs successfully. And in the first instance, try to describe why understanding effective management and leadership skills for integrated care really matters before going into some of the evidence or some of the experiential evidence around what matters when it comes to or what evidence demonstrates effectiveness in leadership and management. And I suppose we start where we look into integrated care schemes internationally over the years, and we find that they're often quite fragile affairs. They're often beset by a number of different issues related to politics or finances, governance, that get in the way of their ability to grow and mature and sustain over time. And what we understand from the evidence is that these sort of integrated care programs, they don't happen in a vacuum. They're not natural evolutions from where we are in today's fragmented healthcare systems. They require constant effort to nurture, constant effort to manage and to lead. And within that, the ability to build social capital and to address things like social norms and values and culture. These are very important aspects, because ultimately, when you look into the most successful programs, the people who are part of it, they're really part of something that they believe in. Belief is such a really important part of this. It doesn't necessarily need evidence that this is going to improve healthcare outcomes or evidence that it's going to be more cost effective. It's evidence that people feel that what they're doing is making a difference both to them as an individual, to the organizations that they represent, and to the communities which they serve. But the problem is, when we look into the evidence around integrated care, what we find out is that our understanding of implementation is fairly weak. So if you can imagine a ship trying to navigate an ocean, maybe off the coast of Australia, close to here, and we're beginning to understand what the building blocks of that ship should look like, how it should be constructed, the nature of its design, We even understand a little bit about the nature of the ocean and what it means that we're trying to do as we sail across it in order to meet our objectives. But I think one of the problems that we have is a lack of understanding, not of the design, but actually of the implementation of how we're going to sail that ship and how we're going to reach our destination successfully. And the problem with that is, if we don't have the understanding of what it's going to take to be the captain of that ship or to be supported of the crew of that ship, our ability to sail that successfully becomes incredibly problematic. It requires that implementation knowledge. And if leaders and managers don't have that information, they begin to navigate in the dark. It's a bit like a ship without a compass. And therefore it is a voyage of discovery. And many leaders of integrated care and many managers of integrated care will describe it as such. A really interesting journey. And had they known where they start, had they known now what was going to happen when they started, they probably would have done things a lot more differently. So our understanding of management and leadership issues is actually not as strong as we might think. But what we do know is that integrated care is a very complex affair. Even when we go down to the basic brass tacks of a simple integrated care approach that might include, I don't know, a GP, a nurse, a social worker, and a technician working together in a small team to deliver integrated primary healthcare in a community, even something as relatively simple as that. Putting that together in terms of governance and accountability and financing, all the things to make those small teams work, is actually really quite a fraught affair sometimes. And the work to develop the bigger and more ambitious projects like integrated care systems or accountable care organizations can be very long and arduous. So managers responsible for achieving change need to plan. They need to plan ahead. They need to think of it as a change management strategy, begin to develop a coherent approach to understand how they're going to be able to navigate those waters successfully. So when we look to examples of integrated care around the world that have been successful, and they've often been on a journey for a number of years, the question is, how can we explain the success? And I give the example here, which I think the International Foundation for Integrated Care showcased before at its conferences, of the Millam Alliance that developed in 2014 in Cumbria. So you see here for Australian and international viewers, there's a map of the UK, and in the top left-hand corner, we have Cumbria, which is a beautiful part of the world in the UK, full of Lake District, but many sort of English rural type villages and towns who are somewhat cut off from areas where they might get better access to healthcare services. And it was in one of these towns where a GP had to hand in the keys, I think retired, and that meant there was not enough capacity in order to support the community hospital. Community hospital had to close. And this was a rural community that suddenly ended up with no support and no services that it could access. But what they were able to turn that around and think through, well, what can we do to use all of our assets in that community effectively in order to be able to provide us with the health and well-being response that we need? And the idea was to create community care organizations or community-based alliances that thought through laterally, what is this that we can do with our health resources, social care resources, schools, industry, local community in order to make a difference. And over a period of 4 or 5 years, this idea permeated across all of Cumbria, 750,000 people, that by 2018, there were some 20 of these community-based alliances in different locations. And it became one of the fastest transforming integrated healthcare systems in the UK, turning a situation for a community that was losing money year on year into being able to make some financial savings. But more importantly, turning around population health outcomes from statistics that demonstrated that they were close to the bottom of the scale to somewhere in the middle in a really short time. Now, if you go to the project leader, he wouldn't imagine himself to have been a system leader at the start, but that's who he was. And sometimes the leaders of the system are not always the ones who've got leaders in their title. He came up with this integrated care equation. So we need our integrated health and social care teams based around place and pathways. We need activated individuals, carers and families that will be able to respond and be partners in what it is we're seeking to achieve. We need to mobilize communities at scale to support health and well-being. But we also need these change drivers in the system leadership, the architecture, the culture, the sorts of things that are going to be able to make the system tick and move it forward. And the problem with this equation is we don't actually understand what that looks like. there's something more needs to be explained here. And when you look into integrated care, some work and some don't work. And they have exactly the same structure and organization, but there's something about the relationship, something about the management, something about the leadership that is different, that is allowing these integrated care programs to move forward. And a part of that lack of understanding is because, integrated care, if you think of it as a complex adaptive system or a complex network, they're incredibly complex beasts. A lot of the players within that are interdependent. There's a lot of interpersonal relationships. It's a social, cultural, nation-building type activity that leaders and managers have to take forward. And if you think of it as a complex adaptive system, we understand they're also incredibly unpredictable. There are so many different moving parts. It's really quite hard to project manage it in the way that many leaders and managers have learned over time. And yet, unlike a complex adaptive system, which says, well, actually, it's about the laws of interaction, intelligent design, and leadership, we know, as I said earlier, that integrated care simply does not happen in a vacuum, and it needs to be nurtured and led, but perhaps in a different way to the way that we traditionally manage and lead organizations. The other problem for leaders, of course, is a tremendous power imbalance. For any of you who've been involved as a leader or been given the title integrated care manager, what you find very early on is you're somewhere down the scale in terms of your hierarchy and decision making. Don't necessarily have the position power because that's held by the chief executives of the organizations you bring together, so you can't tell people what to do. You don't have the funding power because, again, those resources are placed at different parts around the system, so you have relatively little purchasing power in the system to make change happen. Also, the knowledge is distributed to all of the different professionals and individuals across the system. So there are much more people that are knowledgeable about you, about the hospital, about primary care, or about the social care service than you are when you come to the negotiating table. So there's a big power imbalance as a manager or a leader when you go into these relationships. And perhaps what you might have are some staying power or the power of networks that allow you to form your alliances and try to muddle the way through. But of course, with that power imbalance and also the moving entity that is integrated care, quite a lonely place to do business, quite a stressful environment. The other thing I would also say that why management and leadership matters is that whilst you have a number of different procurement networks and you can bring people together in different ways using transactional economics, actually most of the better networks, the long-lasting ones, are based on trust, and they're based on the ability of people to recognize that they're part of a bigger picture and that they feel confident and able to play their role within that. But trust isn't just about, I'll hand you $5 and I know you're going to give it back to me. Trust has to be built over a number of different years. And what trust really means is that I'm going to deliver a quality of service or a partnership to you in ways that I expect, to my standards. And if you don't do it to my standards, I'm not going to be tremendously trustful about it. So there's this kind of mutual gain that everybody is going to get out of integrated care. And if some people are benefiting without putting in the effort, or some people are gaining the resources when I'm not, or some people are getting the intellectual property when it was partly my idea, then that trust can break down very easily. So part of the role of the manager and the leader is how do we maintain that process leadership to keep everybody playing at the same table. So this is why integrated care matters, because it is a bit like the picture here of the wolf and the bear having to work together, because it's fanciful to think that integrated care is actually a coalition of the willing. When you look at networks of care, it's more like a viper's den of competing interests, lots of Machiavellian instincts, people trying to win over other people in order to be able to get what they want out of the partnership. Rather than what we need to do collectively. So the role of the manager and the leader, if it's done the right way, is to be steward of that environment and somehow try to gain the best out of those networks. So again, back to the point that strong evidence that demonstrates integrated care needs to be effectively led, managed, and nurtured over time. So where does some of the evidence for this sit? Well, when you look into the systematic reviews and evidence around management in integrated care, and I point to a recent article in the journal published last year by Victoria Stein and Robin Miller, two of the editors of the International Journal of Integrated Care. They talk very much around still the lack of evidence that exists around management, and that often it's left to the inner fire of particular individuals to make things happen. Where there's a will, there's a way with integrated care, and somehow we muddle through and manage to do it. But I'm going to point to four lessons I think that the that the literature tends to tell you. And one is around this need to build social capital, the relationship building. And in order to be able to do that, we need to have a clear purpose and vision for what it is we're seeking to achieve, which is normally based on the needs of the local population or of the community, because that becomes a defining narrative that everybody can agree to, because that is the objective ultimately, what it is we're seeking to agree. We set the rules of engagement. Everyone's very clear about their roles and responsibilities, clear about what input they have to put in, clear about risks. We're very inclusive at the design stage to those who are going to gain benefit from the network. We're including the community. We're very much person-centered and population-oriented, not structure-driven and organizationally led. And ultimately, we have to avoid large networks, because as you begin to grow your network and all of the different players within it and all of the different consortia that you have to bring together, costs will tend to rise, inertia will develop, it becomes very unwieldy. And it's very difficult to define what a large network is against a small network, but at some point you start hitting up against these barriers that don't allow you to move forward. And often it's because the networks become so large, it's impossible to manage and lead. So building social capital is one key lesson. Key lesson two, how do we create tie-ins? How do we bind people together in order that they're going to work collectively? Well, money often works, and shared commitments, and maybe there are some governance and accountabilities that governments or regions can set for people to work together. You know, duties of partnership have been around for donkey's years in all sorts of different countries, but it has to be more than that. Often they work quite well where jurisdictional boundaries are common, and you see over the years the development of place-based initiatives where you bring health, social care, and other actors together to think through to a particular geography. I think that's very helpful. Often the people who lead or manage need to be in some sort of neutral or respected space. You know, the coordinating center has to feel as though it's there for everybody rather than led by one organization rather than another. We need network coordinators, brokers, skills. You know, in the 70s, they called them reticulists. In the 80s, they called them boundary spanners. We still need these brokers who have the ability to manage across these different networks and the people to be able to do that. Because ultimately, integrated care, when it works, does have managers who are able to control others in terms of their ability to lead in terms of information sharing or knowledge sharing or contracts or supporting trust or administration. They become the hub around which everything operates. So creating these kinds of ties is very important. And part of the ties is how do we create the mutual gain that the different players want. And money is a part of it. The ability to achieve outcomes for my patients is a part of it. The better work-life balance is part of it. So there's something very important about how do we create these tie-ins, tangible ones. And then we get into some of the management roles that begin to look a bit more like leadership. And herein lies a lot of contradictions. We need to have a centralized position because we need to wield some authority to make the network work, but we're not able to mandate the network because professionals like to work autonomously. They like to work in peer-led approaches, but they don't like to be told what to do. So there's this balance between trust and control. We need to also to be able to bring the clinicians into lead or the community into lead, but we also must avoid the organizational capture that some of the dominant elites and dominant organizations have, which might lead the network to their point of view rather than to others. So we've got to try to promote these mutual interdependencies and promote the net worth, because the network is only going to survive as long as it's useful. And indeed, integrated care, as I said at the beginning, often short-lived, and partly that's because not everybody sees the benefit of being part of that. And indeed, most integrated care projects or networks are often time limited. Relatively few go on for 10 years or more, though there are very good examples. Finally, in that, senior management support. You know, if the senior leaders of all of the different parties are not saying this is what we should do, then it makes it very difficult for you to put your head above the parapet and say, well, actually, I'm going to be supporting this integrated care initiative because it's the right thing to do, if you don't have the mandate from your leaders to take part. So I suppose thinking through those lessons, one of the key things is the governance of the network, the accountability, and all regulators outside a network or outside an integrated care project face a problem associated with their ability to enforce power, and it's a problem of authority. So there's a governance gap, a management gap, a leadership gap. And one of the ways around that is how do we achieve a position where I have been given implicitly or explicitly by my partners, the mandate to manage on their behalf. So how am I providing incentives such as all in the network agree to collective governance rules? How do I develop a network constitution that's based on the notion of dual accountabilities, for example? How can I harmonize those things to the point where, as a trusted center of authority, I'm given the mandate to manage on behalf of my community or behalf of my colleagues? And if I don't have that mandate, it's going to be impossible for me to really govern and support and lead that network effectively. And what about the evidence in some of the leadership issues? And some of these are slightly repetitive because when you get into integrated care and when you get into organizational theory in general, there's not too much difference actually between good leadership and good management. That's a debate for another day, but a key leadership task in implementing integrated care, and I'll point to three things. At the start, at the beginning of the venture, there's a need to develop a guiding coalition, a guiding mind to oversee the implementation strategy. So when you look to some of the early adopters of integrated care, for example, if it was 20 years ago, we'd be talking about virtual wards in Torbay, those of you who are UK-centric. That's about developing multidisciplinary teams working in the community to manage older people who've been discharged from hospital and to keep them as healthy and well as possible and out of nursing homes, and so on. But what they were able to talk about was, if we had the commissioners together and we had the providers and the key professionals, we were able to develop this guiding mind to be able to oversee the implementation strategy by bringing all of the key players together, particularly those in the hierarchical positions, and therefore develop cooperative agreements at the level of policy or decision making. So therefore, your teams and the leaders in those teams need senior decision making level capability and credibility in order to take a change agenda forward, both within health, but of course with all of the other sectors, including the community. And that's often quite a difficult task to do. So we were reflecting yesterday with Helen Parker, who'll speak after me, that it was some 20 years ago when we first worked together at a health service management center. One of the pieces of work that I did then was trying to understand the motivations of care professionals to go into leadership and management positions. And relatively, and about maybe a quarter of these professionals, GPs working in primary care groups, commissioning services, often integrated care services for local populations, about a quarter wanted to do it because they wanted to make a difference to the local community. Another quarter were megalomaniacs who didn't want anybody else to have the power, and they wanted to make the decision because they had to be in charge. Another quarter only did it because nobody else would, and they seemed like fairly nice people, and they were put up for it. And perhaps another quarter were kind of fed up of professional practice and wanted a new challenge and moved in. So all of these people, none of them went into it because they really wanted to be leaders. None of them really wanted it because they had management expertise. And that's really interesting because they're going into these positions without the necessary skills and capabilities to navigate those choppy waters of the sea that I mentioned at the beginning. So developing a guiding coalition. Once you've got those guiding coalition, how do we build support for change from all of our different constituencies? Integrated care means different things to different people. The view of the community, from the professionals, from the managers, from the politicians, they all have different motivations, priorities, prejudices, understanding. And this mismatch of motivations happens in everyday conversations when you get into the integrated care space. So building that support for change has to speak to all of these different constituencies, so you're able to come to a common understanding. And this needs careful handling. It's a highly relational task. It invests in the development of the social capital that I've mentioned before in terms of how we develop awareness and understanding of what we're trying to achieve and begin to build an understanding of the priorities and the ways in which we're going to work together. And again, being inclusive through all the stages of integrated care, from design and delivery through to monitoring and evaluation and reflection, is necessary. And we have to avoid any top-down mandates for partnership working or indeed any recognition that this isn't a collective enterprise. And then when it comes to the local level, the place where real transformational change happens in multidisciplinary teams working with and around people in local communities, how do we support them to collaborate effectively? Because it's one thing to say we need a multidisciplinary team and we put it together. It's another thing to say, is that team actually going to be successful in its operation? In fact, the majority of them are not. So Robin Miller in his presentations will demonstrate that most teams have a real drop-off in productivity early on And if they're able to survive and be supported, that productivity will increase once they get to know each other and understand how they're going to work together. So how do we address those workforce competencies? How do we support the emotional intelligence of people to survive in a team environment? How do we strengthen and build those ties between partners in care to establish trust and a willingness to take shared accountability for outcomes? This requires teams to have legitimacy, to act, their ability and skills to work together, and to address those different language barriers and all sorts of other communication elements, because communication is such an important thing here, because communication will breed behaviors, behaviors will breed trust. Trust allows you to knit together an approach that's going to give you an opportunity to meet those collective activities. And if I run out of time, so I will finish with, what some of the evidence tell us from integrated care literature. This is Morell and Minkman's excellent development model for integrated care, now some 10 years old. They talk about the need for leaders to have a long-term commitment to the projects that they're doing, not just a few years and then they move on to the next enterprise. If you look at a lot of integrated care programs, the leaders have been there for a long time. And what they do is they support shared or collaborative leadership, that guiding coalition for change. They build new skills of their leaders or of their managers to be able to collaborate effectively. It's actually a competency that they support. And there's this thing called transparent entrepreneurship, which basically means I'm going to do absolutely anything necessary that's going to make us achieve the vision that we've collectively set for ourselves. And as a leader, I'm going to hold absolute accountability for those outcomes, regardless of whether I have the ability or the authority to be able to make them happen, because I am the system leader and these are the outcomes that I'm looking for. I'm going to do everything in my power to make it happen. And when you talk to some of the key leaders who've been through this space, key political leaders like Ken Kaiser and Rafael Bengoa that you see on the screen there, I apologize, they're two middle-aged men. Next time I'll put up Kathleen Gottlieb from NUCA and change that around. But they will say the same sorts of things about communications, about we have to be disruptive, we have to be brave, we have to take agenda to a policy level in order to make things happen. But we also have to promote distributed leadership. And I'm tired of seeing so many fantastic schemes when the leader disappears and the project then falls off the edge of a cliff. And if we promote that distributed leadership, particularly amongst our community, when that leadership begins to end, the traditional leadership, new people are able to come in because the people in the community in that area wouldn't have it any other way. And you promote a distributed leadership, and that's a sustainability strategy for the projects that you're taking forward. And I won't go through all of these. This is a summary of what I've just said and the evidence from various leadership studies from places like the King's Fund and elsewhere that put a lot of time into thinking through what does leadership look like and what are the elements. But I suppose I finish by saying, management and leadership of integrated care, it's not so very different, actually, in terms of how you would lead an organization. It's just, to a degree, much more complex. And whilst we understand the building blocks of integrated care, and whilst we understand many of the design features of integrated care, and whilst we can point to many of the frameworks for integrated care, we lack an approach that builds the skills and capabilities of our leaders to be able to manage and cope in the integrated care environment, and therefore undermine our ability to replicate, scale up, and sustain integrated care partnerships in the long term. And I think it's such an important area. I hope that's provided some food for thought to stimulate this morning's conversation. I'm looking forward to contributing further. And with that, I'll hand back to Neve or to Frank to take this morning's plenary further.
Thank you so much, Nick. What an absolutely stimulating and thought-provoking presentation this early in the morning. It really has set the tone for the panel, and I'm sure there are going to be lots of questions, but more importantly, lots of very useful conversations when we reach our panel section of this particular session. So given time, what I propose that we do is that we move ahead with our next distinguished speaker. And it's my great pleasure to introduce Alison Verhoeven. Alison is the Chief Executive of the Australian Healthcare and Hospitals Association. And we are delighted to have Alison join us. She's going to be talking with us today in her session about achieving value-based healthcare, reorienting funding and financial incentives. And what a lovely segue from some of that philosophy and how to work into Alison's session. So Alison, I'll hand over to you. Thank you.
Thank you very much, Frank, and good morning, everybody, or good evening, wherever you are in the world. Thank you very much for including me in today's session. And it is terrific to follow on from Nick's presentation, because one of the things we know about value-based healthcare is that programs that are implemented around the world are generally only successful where leaders are absolutely committed and integral to the design of those programs. Leadership, and particularly clinician leadership, but also consumer leadership and partnerships in this space are really essential to success. But what I've been tasked to do is talk to you about funding and financial incentives, and I'm going to try to speak about that in the context of value-based healthcare and how that relates to a better integrated health system for us all. So firstly, one of the key challenges is to actually understand what value-based healthcare means, because it means different things to different people and different organisations. So for any health leader looking at a value-based healthcare program, the first point is to actually think about what you're trying to achieve and what your definition is of value-based care. Is it cost minimisation? Is it cost effectiveness? For many people, value-based healthcare is about budgets. Some people confuse it with a focus on values, for example, on equity or on health as a human right. For some, the term is interchangeable with the triple or the quadruple aim, and it can be considered as an approach to quality improvement. For some, it's about reducing low-value care, for example, implementing programs like Choosing Wisely. And what I'd suggest to you is, in the presentation that I'm going to give to you today, is that value-based healthcare includes all of these elements. It's not one or the other, it's all of them and a little bit more. So let's take the quality improvement perspective as an example. So in a Boston Consulting Group analysis of value-based healthcare projects around the world, they summarise the approach as a virtuous improvement cycle, improving health outcomes at a given level of cost. So in this definition, the starting point is the collection of outcome data and the analysis of variations in those outcomes in order to identify current best practices. And the aim of that is to change behaviours with the intent of enhancing value. But interestingly, as Nick would have pointed out in his presentation, you can't change behaviours if you don't have leadership. So I can't see leadership particularly in this virtuous cycle. And also, this improvement model doesn't include measurement of costs or an evaluation mechanism to determine value. It focuses primarily on outcomes, not on what we might more broadly consider as value. In the classic definition of value-based healthcare, the work done by Porter and Teesberg initially in 2006 at Harvard University, value is proposed as being the outcomes that matter to patients over the costs of delivering those outcomes. But what does that actually mean in practice? So what's in scope for outcomes is both the outcomes that matter to patients, the improvement in their health status, but also the experience that they have of the care that's provided to them. And Elizabeth Teesberg describes that as a comfort, calm and capability framework. So the experience of healthcare. And then the costs are both the direct costs of care, and importantly, this isn't just over a single episode of care, but over the course of a person's care journey. And from a patient perspective also, it includes the indirect costs, things like loss of income, costs of care, from the informal carers that often play such an integral role in the health experience of patients, transport costs, lost opportunity. Those are some of the costs which aren't traditionally in scope when we talk about cost effectiveness in healthcare, but in a value-based care approach, we do take them into account.
Alison, you're not sharing your slides.
Oh, sorry. Okay.
Before you go any further, I just thought I'd let you know. Sorry, I was looking.
Sorry, I will just immediately fix that. You haven't missed anything anyway. Sharing now, I think. You can see them?
Yes, looks great.
Yes. Okay, so you haven't missed anything so far. So who defines outcomes? That's the next key issue. So typically in the past, outcomes will have been designed by clinicians, by coalitions of health services that define what's important. But in a value-based healthcare approach, we think about the outcomes that matter to patients. And there's a really important role for patients, for patient groups, and for society more broadly to contribute to some of that thinking about outcomes. So an example might be in prostate cancer care. So typically in the past, the clinical outcomes that would have been considered important if you were having a surgery or treatment for prostate cancer would be that the cancer had been removed, had been successfully removed and managed, and the patient was recovering from their cancer. But the outcomes we know that matter to individual patients in prostate cancer care include a whole range of other issues. Things like, will a person continue to experience urinary incontinence for an extended period or even for life after their surgery? Will they experience erectile dysfunction? What impact will that have on the quality of their life? So those are some of the outcomes that matter to individual patients that are taken into account in a value-based healthcare approach. Importantly also, and particularly in countries like Australia and the UK and elsewhere where universal healthcare is a goal, we also need to focus on population health outcomes, the outcomes that society is willing to pay for, and the outcomes that we think all people should be able to access in their aspirations for good health. But we do recognise at a population level that the resources available to spend on healthcare are finite, and therefore some outcomes that might be considered both clinically relevant and also of importance to patients may not actually be able to be supported by public funding. In Australia, that's the work that committees like the MSAC and PBAC that are run by the Commonwealth Department of Health do when they consider new treatments, medicines and therapies that should be funded under our Medicare and PBS schemes. An example where we really focus in on population health outcomes when we think about new treatments might be a new drug treatment for a rare cancer. There might be really strong clinical evidence to support providing that treatment to a patient. Patients might also consider that that treatment will allow them to achieve their goals, the outcomes that matter to them, for improved health. But governments are responsible for the allocation of scarce resources, and they may not be able to fund the care that's requested. So some care that patients and clinicians value may not also be more broadly supported by the wider clinical community. We've all heard debates, for example, about costly surgeries for brain tumours by some surgeons, which aren't broadly supported by other surgeons. We know that patients may desire some of those treatments, but there may not be sufficient evidence to support public funding for them. We may see care being provided at end of life, which is futile and difficult to rationalise, even though there may be a demand for it, a demand both from patients, but also a willingness of clinicians to offer it. So at a population level, we do need to think about the outcomes and the value that we attribute to healthcare. And one of the ways we do that is by using data like clinical quality registries. And I'd like to speak a little bit more about those because they're not the simple answer to value-based healthcare that we might think they are. So one of the issues with clinical quality registries, in my view, is that they're often led by clinicians in the development of them. So the ability to actually think about the outcomes that matter to patients in those clinical quality registries is often not there. There's a few exceptions, and I go back to the prostate cancer example. If you have a look at the prostate cancer registry, there are very clear measures in there in Australia around outcomes that matter to patients. But then I'd say have a look at the orthopaedic registries in Australia. Most of those data collected in those registries are actually focused on clinician-led outcomes and not necessarily on some of the outcomes that might matter to patients, like, for example, functionality and mobility. They're more focused in on some of the safety and quality elements around different types of prostheses. So It's important to recognise that clinical quality registries will have a part in determining value, but unless they actually include outcomes that matter to patients and have patient engagement in them, they're not really going to meet the ideals and objectives important for value-based healthcare. So a solution to that, and that a number of colleagues around the country are working on, is patient-reported measures, particularly patient-reported outcome measures, but also experience measures and activation measures. And they themselves can also be very useful in helping determine value to patients, but also value at a population health level. The one experience that a number of my colleagues have had in implementing value-based care programs around the country has been that sometimes these measures can be overwhelming. There can be so many of them, and they can be competing in their interests, that it's actually very hard to make a change in a program when you're not able to drill down and refine measures more appropriately. So one of the recommendations that many of my more experienced colleagues in value-based healthcare programs put forward is that we really need to distill down patient-reported measures to those that focus on the real pain points for patients, where meaningful change can be made to models of care. One of the risks we all know about data is that when there's too much and when it's not comparable across providers, it can become a sea of meaningless information, and this can be driven by our overwhelming desire to embrace everybody's interests and be democratic about things. But we do need to really focus in on why we're collecting these data and what difference they can make in a program. One of the ways we can do that, I mentioned the focusing in on the pain points for patients. Where are the things that really don't work for patients? Those are the areas where we might want to focus in on as we look to achieve better value in our health programs. One way to do that is to undertake really effective patient journey mapping at the start of the design of a program. Really, focusing on co-design as being a central way to kick off a development of a model of care which focuses in on value. And I've just put up a link here and happy to share this afterwards with you. This is a free toolkit that AHHA has worked on with the Consumer Health Forum and others. It's available, anyone can use it, you can download it and get started on the co-design patient journey mapping journey, and we welcome you to use it. The International Consortium of Health Outcomes has a whole lot of work available now on standard sets that have been developed by international working groups of clinicians, registry leaders, outcome researchers and patient advocates. The kind of data that they use or that underpins the standard sets is administrative data, there's clinical data, there's patient-reported data, and this covers more than half of the global disease burden now. This is an example of the ICHOM pregnancy and childbirth standard set, for example. And what I wanted you to have a quick look at on this slide is to start looking at the cycle of care from an anti-clockwise perspective. So looking at the lighter green shading at the top of this diagram, you can see that it's really starting with experience. So I talked previously about patient-reported experience measures. They're integral to the birth experience, but also the clinician perspective of the birth experience. There's words in here that you will see and expect to see: shared decision-making, confidence in care providers, and then moving right around to health and well-being, not only during birth, but after birth. So areas like postpartum depression. So moving around, but then also taking into account morbidity and mortality. And these are in the darker green parts of the circle, where those data will generally be drawn from clinical registries and administrative data sets. So you can see that data is actually key to thinking about value, and this will relate very much then to some of the funding decisions which may be implemented. So as we start to think about funding then, we need to think that we need to acknowledge that healthcare is realised over time. It's not something that occurs on a day and then is finished, or sometimes is, but it is often not something that occurs in a single day. So what we think about when we think about costing and pricing and paying for value-based healthcare is starting to think about a longitudinal view of healthcare. And that has real implications for both patient data capture and the associated system infrastructure, but also has some lessons for us as we think about the costs of care and thinking about particularly the full cycle of care and those direct and indirect costs that I mentioned earlier. One way that this has been taken into account in the typical Porter and Teesberg approach to value-based healthcare is to start thinking about using processes, accounting processes like time-driven, activity-based costing. And that's particularly useful where a health service might want to compare the cost of delivering care using different parts of the workforce. For example, a GP providing care to people in residential aged care compared with a team model, which uses a GP, a nurse, maybe a pharmacist, maybe a podiatrist, other allied health providers. So when you start then looking at what costs this much to provide care on the traditional model, but it may cost this much, a different amount of money to provide care using a team, we can start to make some decisions about both the cost, but also the value that might be generated for patients. So what's required to achieve value-based healthcare in Australia, and I would say this applies equally wherever you're listening in the world as well, we need some agreed comprehensive outcome measures that matter to patients. We need to be capturing relevant data over relevant periods of time, and that needs to be across providers, jurisdictions, and geographies for the patient's full cycle of care. It's really important, and I agree totally with Nick, that we need local level and regional level service delivery, and we need organisations not to be too big. But if we're talking about population-based healthcare and equity in populations, we do need to be able to compare data over time and across populations and across geographies. That's really critical if we're going to achieve equity in our health system. So I'm really focused not only on individual programs thinking about the data they need to manage their programs, but also thinking about the data that will support comparison across our country in order to ensure we've got an equitable approach to healthcare. We also need to be thinking about measuring all the costs incurred in achieving the outcomes that are realised, and that's why patient journey mapping is so important, because what we see in patient journey mapping, and typically when we conduct these exercises for different models of care, the pain points are not only about poor outcomes being achieved, but they're also about the significant costs that are incurred. And a classic example is in cancer treatment, where we think, you know, for example, in the public system in Australia, you can access cancer surgeries, you know, you can access that care and it's fully funded by government, but it doesn't take into account, as we think about the patient journey through the system, the costs that patients might incur before they even get to hospital, in terms of diagnosis, in terms of tests, in terms of lost income. It doesn't take into account what they might incur after they leave hospital for, you know, and having had surgery, when they've got to access drugs that they can't afford to pay for, when they've got to have, you know, chemotherapy provided in a private service to accompany some of the public treatment that they've had. So we really need to think about measuring costs incurred right across the patient journey. The other important point, I think, is, and particularly for health system managers, we need to start thinking more about team-based care. We need to be thinking about how we can ensure all team members are working to the top of the scope of their licence, not to the full scope of their licence. And I think that's a really important change that, you know, we need to start bringing into the language that we use when we start talking about health service provision in Australia. This will require coordination and leadership though, and this goes back to the presentation Nick gave. It's so important to have leadership if we are actually to have effective teams working. Teams don't just form by themselves, they do require leaders, and that requires investment from the system as well. We need to be investing in data, and we need to be investing in technology to make sure that we can actually achieve integration and value in healthcare. And we need to be thinking about equity. So those data need to be informing some of the decisions we make as we start to distribute health services around the country. My organisation has been doing lots of work on value-based healthcare. We're publishing a lot in the space at the moment. It's a really emerging space in Australia, partly supported by some of the, I guess, imprimatur that's been given for value-based healthcare through the addendum to the National Health Reform Agreement. We've got many, many cases around the country now, programs which are being implemented and which are starting to report learnings, both in terms of the funding and financial incentives, which will make them viable, but also about the outcomes that are being achieved for patients and more broadly for our society as we aim to have a really equitable health system. We're publishing a lot of those learnings as grey literature, trying to get them out quickly, publishing lots of case studies, sharing webinars almost monthly on things that are happening, and I really encourage you to join in and access those. Most of them are available free of charge on our website, and we're really appreciative of everyone who's sharing that information. And I would like to end there by saying thank you very much for inviting me to contribute to the conversation today, but also to acknowledge that you can't achieve integrated care in health system if you don't think about value, because you'll never be able to pay for it. So value-based healthcare is absolutely key to achieving integrated care. Thank you.
Thank you so much.
Thank you so much, Alison, for that thought-provoking presentation. How beautifully you tied some of the philosophies
that Nick made into the pragmatism required to deliver integrated care at a systems level. I'm going to ask my co-host, Niamh, if she's got any reflections or if there are any questions popping up in the chat. Niamh.
Thank you, Frank. So, if I start very quickly just with a reflection that's also a little bit of a question, and then I have one question that has come from the audience. So as I was listening to both Nick and Alison, and given that I know the experience of COVID-19 has been perhaps different in Australia than some other parts of the world, but nonetheless, in the context that we've seen integrated care in other parts of the world become almost accelerated by the response to COVID-19, I wonder whether you see any potential in systems, leadership and governance, but also in articulating the case for value-based care. There being an opportunity through our current experience with the pandemic. So Nick first and then Alison.
Alison might be able to directly answer that better than me. My impression is not so much in Australia. That's just my impression. I think there had been a direction of travel before COVID, in any case, that starts to think around value. But there seems to be, the focus, it seems to me, still at the heart of, the heart of the Australian government, and indeed in some of the states, is still entrenched to some degree in a medical mindset, and the ability to grow systems and approaches that focus upon improving access. And yes, value is a part of that, but it seems to me that highly value, as we see in many other systems, is the need to ensure that we reduce unnecessary utilization of certain institutions like hospitals, and find a way to do things more cost effectively. So when I look at things like the telehealth agenda, for example, and in Australia, it's glorified video consultations versus what happens in other parts of the world where we're using it as a means to support self-care and a whole range of other means. I think we're a long way behind. So I don't get the feeling that perhaps that COVID has necessarily accelerated the ideas around integrated care or value-based healthcare as perhaps it's done in other countries. where there's been no alternative but to look to your community assets to make a difference. So I don't necessarily see it, but then, you know, I'm slightly academic and ivory tower, so maybe I'm not at the front line seeing a few things. I have seen some things change, however, when you've needed to do things differently in order to, say, address you know, people who are, you know, needing knee replacement therapy or something, and you can't manage them in the normal. And we're thinking through different types of approaches and different types of things which we could do to achieve that. So you do see things around the edges, but I don't yet see a fundamental shift. What I do think, however, is that there's a broader pattern of change towards value, and maybe Alison could say more about that.
Thanks very much, Nick, and thanks for the question, Neve, and the audience. Look, I think there's two aspects to that. Firstly, I think one of the sort of key elements in both value-based healthcare and in integrated care theory is that social determinants have a really critical role to play in the achievement of health. And we have learned, I think, very much through COVID that not thinking about the social determinants actually makes our health more fragile as a community. So in Australia, specifically in Melbourne, I could say during the outbreaks, the second wave of outbreak last year in Melbourne, when there was a lockdown in public housing towers because of an outbreak of COVID, some of that was related to casual work. Insecure work, people not having sufficient funds to be able to stay home from work when they were ill, people not being able to access care. And then the fallout from that was them being locked down in towers where they weren't receiving appropriate food, they weren't receiving mental health supports. So we know that, you know, that makes a community fragile. And the flip side of that is how well we've done in Australia in terms of supporting Aboriginal communities to avoid the impact of COVID during 2020-21. The Australian approach to protecting Aboriginal and Torres Strait Islander communities meant that Indigenous people in Australia actually had a lower rate of COVID than non-Indigenous people, and compared with Indigenous populations around the world, it was a pretty outstanding result. So that's one aspect of value I think we've learned from COVID. The second aspect is that there are many different ways to deliver healthcare, and we experimented with a lot of them during 2020 in a way that we've never been game to do before. I was quite hopeful that we might have actually learned something from that, you know, setting up virtual hospitals, you know, integrating wearable devices into, you know, delivery of care, not necessarily sending everybody off for knee surgery, but getting them engaged in weight loss programs, you know, things like that. There are different ways to deliver care, and a lot of them bring more value to patients, but also more value to us as a society. But sadly, I'm just coming out of having read the budget papers from Australian government budget delivered last night, and I don't think we've actually learned those lessons because it was business as usual, just a whole lot more cash for it. So yeah, sorry, I can't be more optimistic.
I totally agree with kind of like the centralized political view. I do see a huge amount of innovation on the ground, particularly in some of the metropolitan areas. So let's not be too dramatically sad about things not changing, because I think there's been a lot when you look locally. But yeah, you're right. I think talking about political leadership from the top, it seems, you know, standard. So it hasn't led to the sea change that maybe we've seen in other countries. But
Thank you, Nick, and thank you, Alison. Just to pick up on that last point, beautifully made by both of you. I love the optimism in the conversation around not getting too bogged down in the reversion to the mean or the reversion to the way that we used to do things. I do think from a systems perspective, and I'm violently agreeing with both of you in balance here, that there have been some significant shifts. I think for our audience online and for everyone on the panel that I'm about to introduce, I think that we are probably all in the same camp as being relentless optimists. So anything other than a rapid advance and an uptake of a change and a change mindset is always going to appear as a disappointment. But I'm a great believer in nudge theory and the fact that perhaps we've nudged the system a little bit more than we might have been able to do without the assistance of the pandemic. Now, for those of you who've been online and listening to our excellent speakers, and thank you so much, Nick and Alison. You will have heard in Nick and Alison's presentations that they referred to consumer involvement in the work of integrated care and how important that was. And to that end, it's my great pleasure to introduce Melissa Fox, the Chief Executive of Health Consumers Queensland, to our panel. And I'll throw to Melissa in a few moments to introduce herself. Well, you also will have heard about the role of innovation in keeping the momentum in our systems and processes and keeping us moving forward. And to that end, we're delighted to invite from Singapore, Tamsin Grulich-Smith, who's the director of the School of X Design Singapore Council. So the next part is that you'll have heard about the importance of networks and what a fragile thing they can be. And Nick referred to the scale of those and really not being quite certain about what's too big and what's too small, but reflected on the power of networks and the importance of leading those and nurturing those. And to that end, we're joined by Helen Parker, who's the Chief Executive Officer of Pinnacle Midlands Health Network in New Zealand. So may I welcome each of you to the panel. We'll now have a discussion for the next 40 minutes or so and a conversation about the things that are important. And Niamh will facilitate some questions, please, that emanate from our audience, but also some of which we've prepared earlier to keep you on your toes. So can I go to you, Melissa, first to introduce yourself and perhaps just set the scene for your context.
Sure, thanks, Frank. And I too would like to start by acknowledging the traditional owners of the land on which myself and Frank are, the land of the Jagera and the Turrbal people, and pay my respects to elders past, present and emerging. And thank IFIC for this opportunity to gather from across the globe to talk about something that's so important. From a consumer perspective, it's not about the cost or the challenges of implementing integrated care. It's the cost to us and to the system of not doing it. And I'm excited to have a conversation and share some examples today about the power of placing consumers and the community at the centre of that process and how that's actually such an enabler to overcoming some of the challenges. So thanks, Frank.
Hey, thank you, Melissa. Tamsin, over to you.
Good morning, everyone. Well, it's morning here in Singapore anyway, so hello wherever you are. So yeah, I run something called the School of X at Design Singapore Council, and the aim of School of X is to help everyone to understand how they can embark upon co-design experiences towards desired outcomes in complex settings, so very relevant. Before I joined Design Singapore Council, I founded something called the Smart Health Leadership Centre at the National University of Singapore. And that was really around looking at the role that each of us plays in achieving desired health outcomes. So moving away from healthcare redesign, as it were, and actually starting with the desired outcome and looking at the variety of tools we might use to get to those desired outcomes. I always believe, and I think the previous presentations have shown us this, it has to start with people. So we always start with this human-centered design lens, and then we look at the other enablers, of which I think we'll hear plenty in the next 30 minutes or so. So yeah, I'm looking forward to throwing that human lens into the discussions as we go along. Thank you.
Hey, thank you, Tamsin. And finally, to you, Helen.
Kia ora. Good morning, everybody from New Zealand. And thank you, Frank, for the acknowledgement, speaking as a nurse with a nursing background, for the acknowledgement of International Nurses Day. And of course, within the topic of integrated care, the nursing contribution is really valuable. And thank you for asking me to be part of the this panel discussion. It's very timely for New Zealand because, as some of you may know, the Minister announced significant health system reform a couple of weeks ago, coming from the English health system, and I've only lived in New Zealand for 8 years, working in a system that hasn't seen significant reform of the structures and processes for 20 years, it has been a luxury compared to my probably English colleagues who may be online who have had fairly frequent system restructures. The reason I'm saying that is one of the things I've learned is that, and it plays to some of the comments that Nick made in his presentation, that when you're working in a system that hasn't had significant structural reform for a long time, relationships are able to be developed and built up, and we certainly saw the value of that in terms of managing COVID. The health system reform is large that we're about to enter into is largely based on the development of integrated care networks. So this is a very timely discussion for us.
That's wonderful. Thank you for that introduction, Helen. So welcome, panel members. I'm now going to go across to Niamh, who is going to facilitate, if you will, this portion of our presentations and the conversation with the panel. However, don't be surprised if there are interruptions with questions online, and if I, from time to time, interject, because I can see that there's a very stimulating conversation just about to be had. Over to you, Niamh.
Great, thank you, Frank. So I have a question which brings together some of the elements of questions that are coming in on the portal, but also I think mirrors a concept that has come up a number of different times from both Nick and Alison, but also mentioned by the three panelists, which is around this idea of social capital. So you talked, I think, all of you in different ways about the importance of this focus on social capital in the context of delivering integrated care and person-centered, user-centered integrated care. I wonder whether you have any ideas about how we measure social capital in this context, and how we incorporate this then into how the value that we place on integrated care and new models of care. So who would like to try that first? Helen?
Yes, I don't mind going first. I mean, I think this is the crux of some of the discussions that we're having here. And, you know, I should have said at the beginning, you know, I lead a network of 86 general practices, and we also deliver a large range of health and care services. So the concept of integrated care is forever present. I'm going to be slightly provocative in the interests of generating a good debate, is I think, and I have huge respect for Nick for continuing to champion this for the last 21 years. I think a critical leadership question, and it is related to the social capital, is have we all become desensitized to the whole concept of integrated care, because we've been talking and rehearsing the same discussion for such a long time. Although I do acknowledge that we're, you know, presentations like Nick did this morning is talking to a new generation of clinicians and leaders that weren't with us 21 years ago. So for them, it's more relevant. But I think it's almost become the emperor's new clothes, and I found more traction in generating improvement in services for the people that receive the services and communities, and for the value of the health dollar in terms of that values approach, which for me link to the social capital. Are we achieving better for the people that we're delivering services to, and who's defining what that better is? Is it the consumer? But I'll let Melissa speak to that. And I'll be looking at the health dollar, that we've lost that focus on social capital because of I think the narrative over the 21 years about integrated care. And I've certainly found removing the term integrated care from any of the discussions and focusing with providers, with patients, clients, and then from a governance perspective on what are we trying to achieve from a consumer perspective and from a system perspective, actually gets more traction just by dropping that term. So I know that's being slightly provocative, because I do think we've become desensitized to it and we don't know what it is. It was interesting that, you know, Gemma Hughes and Tricia Greenhouse brought out a paper last year called Rethinking Integrated Care. And I think they make this same point, that I do think we need to reframe it. And I think we're starting to see social capital here. And of course, we could get in discussion about how you measure that, because we've returned back to what does better look like. And I often think we use the term integrated care when we know care needs to be better, but we can't really articulate well what better looks like, because we don't spend enough investment, time and focus on talking to the people who the care is being delivered to and with, to what does better look like for them. And then also, how do we do that most cost efficient? Because that's the way that we'll achieve social capital.
Right, thank you, Helen. And provocation always welcome at our conferences. So thank you for being provocative. Melissa, I wonder if you could share your thoughts with us on that.
Yes, look, thanks, Neve. It's been really interesting to be a part of conversations at every level of the Queensland health system with people, with leaders who are so passionate about delivering value-based healthcare and integrated care. And I often reflect on, if the majority of us are on the same page, why hasn't it happened? And I think that the missing piece here, and it's been made harder through COVID, has been the political will to understand that actually this is the solution to the huge challenges that are facing our health system. And it is about working with consumers and community to get a shared commitment to this and making it happen. And an example that I'm thinking about that really reflects what Helen is talking about, and Frank will know about this, Children's Health Queensland have been involved, is the Logan Community and Maternity Child Health Hubs. So an enabler for that project to happen was actually a backbone organisation called Logan Together, which was that independent third party that Nick talked about, with resources that was able to bring together community members, community organisations, the local health services, different parts of the department, primary care providers, and do a collective impact co-design process that really created that shared vision for services, integrated services, midwifery, continuity of care provided in a community centre with wraparound social and community services and other health services, would deliver better health outcomes for at-needs populations. And having a layer of the consumers and community lobbying politicians for funding and helping to overcome some management resistance to that model for some time really enabled that incredible model to come to fruition. And it's now delivering care to those families. It's supported by a community governance mechanism, of which I'm the co-chair of that committee, which holds the health services and the hub locations to account for delivering on that co-designed model of care moving forward and how it's improved. So it is possible, but it is about that place-based, mobilising the community to overcome the challenges and having the funding mechanisms to do so.
Great, thank you, Melissa. And Tamsin, from a user-centred design perspective, what would be your take on the view of social capital and how we measure it?
Yeah, I thought, wow, this is a really interesting starting question, seeing as I've been up since 4:30 this morning. How do we measure social capital? And while we're at it, how do we solve world peace? But to me, it's actually another word that's come through every single thing we talked about today, which is about trust. Integrated care is massive change on every level. And in all my experience of running design programs in very complex settings, my experience is that people start with the solution in the way they frame the challenge. And that's why it always feels a bit awkward, because we're trying to push a solution into something without really understanding, is this the right way of going about it? So we've always driven people to think about what's the desired outcome. And frankly, and I love Helen being provocative, because normally I'm doing that as well. So yeah, we'll have fun this morning. The phrase I always teach my students and my clients to ask themselves is, who cares? And it's quite an empowering thing actually for them. I've had people come to me and say, it's transformed the way we've had our conversations. I had a director of a hospital come to me delighted one day to say, I sat in the middle of a meeting and I suddenly threw down my hands and said, who cares? Why are we doing this? Really, what are we hoping to achieve? She said it reframed the whole conversation, and we really began to flow. And the key thing first there is she felt safe to do that. So this sense of safety, which is all about building relationships and feeling I'm able to actually express this. And then the sense of why are we all here and what do we all care about? I've tended to work in a lot of projects there's been a lot of conflict. In fact, I get dropped into projects that are in conflict quite a lot. And it's really about saying, no matter how different your objectives are, you can normally find that win-win point. And the other thing I would say is it's really getting beneath the headline of that. So do we want integrated clinical care pathways? Yes, we do. But I think it's been touched upon several times today. What it means to one person might be very different to what it means to another. So really scratching beneath the headline. And it's interesting, I'm on a project at the moment where we're discussing similar things. We all want best customer experience in the world. Okay, so what does that mean to the CEO? What does it mean to the CFO? What does it mean to this person? What does it mean to the customer? And in fact, who are your customers? What does it mean to the frontline staff? So when you start to scrape beneath the headline, everyone agreed, yeah, we want to provide the best customer service in the world, the best customer experience in the world, but it actually meant very different things. And I love the fact that halfway through the conversation, someone said, we've all got a completely different view on this. Brilliant, then the conversation could begin. So how we measure social capital, well, okay, that's a whole big one, but I do feel it's essential as a starting point. I believe before we go anywhere, we have to resonate with the people we need to connect with, so they're on board. They have to see a reason for contributing, and they have to feel they're going to gain as much out of it, if not more, than they would by putting in. So that very mercenary kind of transactional lens of what's in it for me really does help to get that sustained traction above and beyond the individual. So yeah, that's also a little bit varying, but those are my views on it. We start with the people and then work together.
Great, thank you, Tamsin. Nick or Alison, any thoughts? Nick?
I'm happy to give some thoughts. You're asking how we measure it. I'm a qualitative researcher by background, so social network analysis, organizational network analysis is the sort of approach one would take, and the methodology would be things like interviews or questionnaires with different partners to understand who they work with and how they work with and how they feel about those relationships. I've been involved in doing observational techniques as well. So you look at people and how they talk to each other, what they talk about, the nature of the language they use, who's dominating who. There are all sorts of things you can have a look at in terms of observing the way these interactions happen. And then other social network analysis kind of look at email exchanges or information exchanges, looking at the network of things of how people are sending information to each other. So there are ways of measuring it. And I think I haven't looked at that information for years, but it seemed to me that the denser those networks, you imagine that network slide I showed, the denser those networks, and the more that the lines are going in every direction, then the more likely it is for these people to be working in integrated fashion, because the communication is working across everybody. If you're finding that there are outliers and people who are lost or isolate in the system, then the network isn't working in the same sort of way, and therefore the social capital potentially isn't shared as much. That is at least the theory of what I understand some of the research to mean. And there are specific tools for integrated care. There are specific tools for teams. There are specific tools to understand the health. You know, there was your own readiness framework that you developed previously. It's the same sort of approach in which we're trying to gather this information to see how cohesive we are. So lots and lots of different ways in which we can try to get the handle on social capital. But also the proof's in the pudding. So look at the outcomes. Are people working together? Are we all turning up to meetings? Are we doing the shared things? So there's also, you can look at the outcomes as well. But I've always talked about social capital right from the very beginning of things, because it is the X ingredient that we need to kind of understand how to foster, because without it, you can still achieve a lot, but actually that becomes much more transactional, and the transactional way of doing things in integrated care can only get you so far.
Thank you, Nick. And Alison,
I actually think more important than social capital, in my view, is actually concepts of public good and social license. I actually think, you know, if we're talking about health systems which have, you know, constrained resources, we have to have a clear understanding of the public good we're trying to achieve, you know, in the outset as we start to consider programs. So, you know, Melissa obviously in Logan, you know, focused on questions that are informed by data about paucity of care, paucity of outcomes in her community. What was the public good goal there? It was to transform that, and what would be the mechanisms to transform that. And then I think flowing from that is social license. That's the arguments you have with politicians and funders to say, you know, we as a community not only want this and believe that it's good for our health outcomes, we demand this. We are giving you social license to implement funding frameworks in this way.
Yes, no systems debate is quite complete without mention of Michael Moore and the strategic triangle and the elements of that. Thank you. That I think there are several more questions I would love to ask, particularly around aligned payment systems, because that was part of the discussion this evening, and how we align all of this with our creaky, messy, probably wouldn't design them that way if we were given a clean sheet of paper payment systems today. But I am also conscious that we have only 6 minutes to go, and that might be opening up a can of worms. So Frank, I don't know whether you want to do a quick wrap up and then come back maybe for some final thoughts to our panelists. You're on mute, Frank. Had to say that once.
That was a rookie mistake. My apologies, everyone. Thank you, Niamh, and thank you, panelists. Look, it was very interesting listening to the responses, and I had 3 key points I wanted to make as a result of some of the commentary that each of you had made. And I wanted to just remind you all of the power that each of you have in changing the system as individuals, and that, you know, while it may seem a lonely and difficult task where you're working, really the power is in networks like this, where you have the opportunity to meet with like minds and feel encouraged and supported around some of the work that you're doing. To the notion of consumer involvement and this notion of consumer power, I love this notion. I love the notion of the people that we serve are consumers, and in fact, we're consumers ourselves. I love the fact that there's much more influence in the system around the consumer perspective and voice. People are no longer just happy to sit silently and wait for you know, an outcome that may not be what it is they need or want. And I think from industry, if you look at the growth and the development of Amazon, for example, how they have harnessed the consumer's voice and thinking, and how they've folded that into a business model that has absolutely taken the world by storm. They asked the questions and they listened to what people wanted, and they have delivered something quite outstanding. Any of us can now get a pair of shoes in our backyard within 24 hours, literally. You remember when you used to have to make a trip to the shoe store and get fitted and do all of those things. So that whole notion of consumer power and influence is important. I wanted to remind you too about your power as leaders. Our responsibility, and I see my responsibility as a leader, is to develop people. And I always keep that in the back of my mind as we move through these, nudging the system to do better and to create change. I want us to always remember that our job is an intergenerational piece of work. So as each of you have talked about, this takes time, and Nick referred to this notion of people taking on projects and then them falling off a cliff. I believe that a response to that is us taking responsibility right now to develop leaders for the future. So our role as leaders is to develop leaders, and that's our legacy. They will do the work. And the last thing I wanted to just remind people about was some of you may be familiar with Socrates, and I'm not referring to the Brazilian midfielder of the 70s, who was a fantastic soccer player. I'm talking more here about the philosopher. And Socrates reminded us that the secret of change is to focus all of your energy, not on fighting the old, but on building the new. And for me, that really does pull together that notion of what it is that we're about as a dispersed network of people who are passionate about and have leadership roles in a network system that we want to see integrated much, much better. So I'll leave my reflections there. Are there any final thoughts from our panelists?
Frank, I'd love to thank you for acknowledging that role of us as leaders and touching on that idea of sharing power. It's actually the theme of our upcoming annual event in a few weeks, the power of sharing power. And I think we've really seen that in Queensland through COVID. Relationships that did exist previously, from partnering around issues such as integrated care and value-based healthcare, were initially tested with the command and control approach early in the pandemic, but really consumers called out the system here in Queensland and demanded to be back at the table. And now we're in the fortunate position of consumers involved at every level of the pandemic response by the government here. And that's what we need to do. We need to all rise above that noise from COVID now, to amplify the consumer voice about what we want from our healthcare system, and take this work to the next level. So I look forward to working with all of you on that.
Thank you, Melissa. I'll draw our session to a conclusion there, and in doing so, I just remind people that the recording of the session is available immediately on YouTube. So pop onto YouTube and have a look. It's free to access, and we encourage delegates and viewers to share this link widely with their networks. Please also encourage people to attend as many sessions as possible, because I believe they'll be excited about the content, and remember that notion of leading the conversation. So setting that context as beautifully as Nick and Alison did, and as this panel did, some people need to hear that conversation. And I just finally wanted to remind you that there is our next World Conference is the first one in North America, and that's taking place from the 4th to the 7th of October, and it will be hosted by IFIC Canada. Now, the call for papers and registrations, etc., remain open until the 31st of May. So more details about that conference are available on our website, and I'm hoping to see all of you there. If not, maybe, fingers crossed, we can even see people in person. Wouldn't that be wonderful? But I don't hold out any hope. I can see Nick respond to that. I'm just being relentlessly optimistic and thinking about my own travel needs. Audience who joined in, thank you so much for taking the time out of your day to join us in this conversation. To our two keynote speakers, Nick and Alison, thank you for setting the scene and for giving us that context, from that philosophical perspective right through to the why and the how. And for Alison then picking that up and thinking about the systems that govern and drive and create the conditions for what it is that we might be able to do, and for being a provocateur in that respect. Thank you to Melissa for bringing that consumer perspective, and for once again, unapologetically and quite rightly just saying, hey, we're here, that we've got something to say and it's of value. For Tamsin, again, people-centered design, Tamsin, thank you again for getting right back to that. How might we measure outcomes if we haven't asked people what it is that they need and want? The fundamentals. But again, it's leaders like you who remind us that that's an important question to ask. And to Helen, thank you for your reflections, Helen, around how to keep the system moving and keep the agility of that network delivering results locally. And that ties us beautifully back into one of the original points that Nick made, is that while our eyes are on the horizon around systems change, it's important that we keep our eyes on what's happening locally and to celebrate the difference that networks, consumers working in partnership through human-centered design can make to outcomes through health and well-being every day. It's important that we talk about that and acknowledge that and bring that forward. Niamh, thank you for being such an effective and helpful support person in co-hosting this session. And to the team at IFIC, thank you all for making this happen so seamlessly. Enjoy the rest of your day, everyone, and see you soon.